First of all, I would like to say thank you, Dr. Mukiva sir, for giving me this opportunity. Today, in continuation with this series of topic in IBD, will be the present in the last topic, that is FMT in IBD. Overview of the topic. The first section is will be dealing with the use of FMT in IBD, and the second one will be dealing with the FMT preparation and the procedure of the FMT. So in first section, we will see what is FMT, whether it is logical for the FMT to use in IBD, whether it is a curative one, whether it is more beneficial in ulcerative colitis or Crohn's disease. Are there any studies supporting its use, Western and Indian? And what is the best time in natural history to use it? Whether it should be used for induction or maintenance of remission, whether we should for mild to moderate or severe IBD, whether we should try it before biologics or after failure of biologics, and whether it can be used in pediatric IBD. The second section will cover the FMT preparation and procedure, how the donor is selected, whether the donor should be known or related or unknown, whether the donor should be single donor or we should use multi-donor FMT, whether what is the best route for using FMT, what should be the protocol, how the donor and recipient are screened, what are the exclusion criteria, and what are the side effects of FMT. So what is FMT? FMT is administration of healthy donor whole stool into GIT of patient with the aim of correcting dysbiosis. So the principle of FMT is exclusion of the competitive organisms by FMT-induced restoration of microbial communities and preventing pathogens to persist and proliferate. The composition of the normal microbiome is bacterial, viral, and fungal communities, and the primary bacteria of intestinal microbiota generally consist of 4 major phyla, which constitute more than 98%, most common big firmicutes and bacteroids, which constitute more than 80 to 85%, and the others are proteobacteria and actinobacteria. If this balance of having more firmicutes and bacteroids and less proteobacteria and actinobacteria changes, then it is called as the dysbiosis, and thus FMT finds its application in the diseases whose pathophysiology involves alteration in microbiome. So whether it is FMT is logical to use in IBD, this thought of using FMT in IBD comes to our mind because of great experience with FMT in cases of recurrent CDI infection. So the pathophysiology in CDI is excessive exposure to the antibiotics leading to the altered colonic microbiota, overproduction of the growth of the C. diff and production of toxin leading to the colitis. So in this case of RCDA, the main pathophysiology is the dysbiosis, where it is a cause. And with the FMT, there was a good success rate with the single FMT about 79% and with the second FMT about 90%. So because of this experience and background knowledge of dysbiosis is the cause in RCDA, we thought of using in IBD because dysbiosis is also one of the arm of pathophysiology in IBD. So definition of IBD is chronic relapsing remitting disease caused by aberrant immune response towards luminal antigens, probably commensal bacteria in genetically susceptible individuals, and is influenced by environmental factors. So the pathophysiology of IBD is complex, having multiple arms, one of the arm being dysbiosis, but we don't know whether dysbiosis is as a cause or effect, and we thought to correct it so that the FMT becomes logical to use in IBD. So the first description of this use comes from a patient, Justin D. Bennett, who was suffering from severe active UC and which was refractory to steroids and salicylates for more than 7 years. He used self-administered large volume fecal retention anemia from single healthy donor and was symptom-free for 6 months. This formed the basis of using and experimenting with the FMT in the another IBD cases. But the next point is whether it is curative or not. So already discussed, as IBD is having pathophysiology having multiple arms. So dysbiosis is one arm. We cannot correct other arms like genetic factors. So it is not curative one. So why to use this drug? Why to use FMT? Because we know that IBD is not curable. No drug is curative. So we can use FMT before trying biologics because biologics are costly, and this becomes relevant in our countries like developing countries. So what are the basis for any studies done previously? So these are there are 4 RCTs. We have taken 2 RCTs for comparison in UC. One is Moidi et al. And another is Rosen et al. Moidi had used FMT in selected 70 patients, and FMT was in 36 patients, and another water enema as a placebo was in 34 patients. They found that the FMT group has good remission achieved about 24 patients, 24% cases, and they also found that those who were having the UC of less than 1 year, they also achieved good remission. Along with, they found that those who were on immunosuppression, they also achieved good remission, about 46%. They also found that they used different donors, but one of the donor was donor B, which Fecal Microbiota has achieved more remission in cases, and they found that there may be some superdonor phenomena where a particular person might be having greater microbial diversity, and so the results are getting better with that particular patient donor. Another study was Rosen et al., where he had used done for on 48 patients, where the 23 patients received donor FMT. So he called as FMT-D, and another patients, about 25 patients received the autologous FMT, means the patient received their own fecal slurry, and they called as FMT-A. The primary endpoint was achieved by 37 patients at 12 weeks, and they found that about 41% patients of FMT-D and about 25% patients of FMT-A achieved clinical remission, but that was not clinically significant. So the inference from these two RCTs, as they have included only mild to moderate UC, we can say that it is more effective in mild to moderate UC. And more effective in early UC, there can be existence of superdonor phenomena, and the lower GI route is more preferable, and multiple sessions of FMT can give good results. FMT was more successful when patients were on immunosuppression. If we consider this one study, Rosen et al., where autologous FMT was used, still, if compared to Moide et al., the FMT results were good even in control groups. So they come to a conclusion there may be some effect of processing of fecal suspension that can do some changes which may be beneficial to the patient. These are different RCTs. We discussed already two. Then second question arises whether it is more beneficial in ulcerative colitis or CD. There was one meta-analysis done by Coleman et al. Done for 18 studies, and they have he had included 122 patients, out of which 79 were UC, 39 were CD, and 4 were IBD unclassified. Overall result were 45% achieve clinical remission of UC, about 22% of CD, 60%. So they concluded that it is more beneficial in CD. Then these are the studies in CD. Most of our cohort study, there were no RCTs. There were two studies done by Sud et al., and these are for induction of remission and maintenance of remission. For induction of remission, the study was done that was on mainly patients of mild to moderate UC on stable doses of immunosuppression for more than 4 weeks. About 33 patients completed the protocol, and they uses two unrelated donors, and in alternate session AB like that, and there were 7 sessions of FMT given on after 0 to 6 10 weeks, and it was by colonic infusion into the terminal ileum and cecum, and the primary endpoint was steroid free clinical remission at week 24, and secondary endpoint was clinical response and endoscopic remission at week 24. The results were astonishing that the clinical remission they achieved in 57% of clinical response in 93 and endoscopic remission in 78%. During the study, they found that Mayo score gradually reduced from every session of FMT, and clinical response increased over over every sessions. With each procedure, the acceptability of FMT also increased, and with each procedure, patients were able to maintain the fecal slurry. These are the baseline characteristics, and this is the table which showing the clinical outcome. From this table, we can see that the Mayo score gradually reduced, and clinical response remission and endoscopic remission gradually increased. The inference from this study is that this can be used in steroid dependent UC with good steroid free remission. Lower GI rate again is preferable, which is seen in the Western studies also. Again, multiple sessions, multiple donor FMT is confirmed considering the two type of studies, and unrelated donors give better results, as diversity of microbiome is more because of unshared genetic and environmental factors. So they further analyzed their study and they found that it is effective in early UC, mild UC, females and younger than 40 years of age. Another study by same group for maintenance of remission. Here they have selected the patients, 112 patients which have attended the induction of remission by 7 sessions of FMT. Out of these, which were stable on oral doses of 5-ASA and ASA for more than 6 months, were considered for RCT. 61 patients were considered, 31 patients FMT and 30 placebo. But they here use only single donor, unrelated donor, rather than multi-donor. And again, 7 sessions of FMT were given every 8 weeks for 48 weeks. The primary endpoint was maintenance of steroid-free clinical remission at week 48, and secondary endpoints were endoscopic and histological remission at week 48. Again, the results were very good. Maintenance of clinical remission was found in 87% FMT and 66% in placebo, which was not clinically significant. But endoscopic remission and histological remissions were clinically significant and found in 58% and 45%. So these are the outcome measures, and this is a bar diagram showing the clinical outcome. So the inference from this study is FMT is effective in maintenance of remission also. It helps in inducing endoscopic and histological remission. Again, the lower GI rate is confirmed as more preferable, and multiple sessions of FMT gives better results, as there were no side effects necessitating the discontinuation of treatment of FMT. So FMT can be considered as having long-term safety and efficacy because the study was conducted over 48 weeks. So what is the best time to use in natural history? So already just seen the early UC gives the better results. So better to use in early in the course, mainly in the newly diagnosed UC on stable doses of conventional treatment when the severe inflammation is not present, and may be used before trying biologics, because the remission rate with the biology is around 20-22%, and with the FMT is also the same. So whether FMT can be used in pediatric IBD, there are the 3 studies, 2 for UC and 1 for CD we are discussing. The Kunde et al. Has done this study in 10 children and given the enemas daily for 5 days. Again, the lower GI route, they found that the clinical response within 1 week was 78%, and remission at 1 week was 33%. Kellermeyer has used this FMT in only 3 patients which were on immunotherapy dependent, and but he has used multiple sessions over a period of 6 to 12 weeks, and the donor was adult, unrelated. These 3 patients all were symptom free at least 4 weeks after the last dose of FMT, and we also achieved endoscopic and histological remission, which was maintained 2 weeks after last FMT. Then this study Suskin et al. Had done on CD, which was mild to moderate, and he had used FMT by nasogastric tube, and the remission at 2 weeks was seen in 77%. So inference from this study is conclusion is that fecal enema FMT is feasible and well tolerated by the children. The FMT in children can be used in UC and CD, and it is more effective, found to be more in CD, and nasogastric tube in case of CD can also give the good results. Adverse were minimal, mild to moderate, and were acceptable, manageable, and self-limiting. So already seen whether why the unrelated donor is better, because different genetic makeup and sharing the different environmental factors. So having the more diverse microbiome, there can be existence of super donor phenomena which can be helpful, and multi-donor FFT is cheaper in case of unrelated. But the disadvantage is need to use the frozen FMT, which is tedious, and logistic and storage problems can be there. Related donors know about the risk behavior, low infection rate, and we can use the freshly prepared FMT, no need of storage. So what is the best route? We have already seen that lower GI route is better. One meta-analysis has shown that the pooled clinical remission for UC and CD is more with the lower GI route, that is 31 and 27% compared to upper GI route. For UC is 8% and CD is 23%. What should be the protocol to use FMT? already 2 studies by Indian people had done, and both for induction of remission and maintenance of remission, where they used colonoscopic route, and they have used for 7 sessions of FMT for induction, 7 sessions for FMT for maintenance. Bowel preparation was done by PEG. Antibiotics priority FMT Indian study has not used, but the Western suggests that you can use metronidazole, amoxicillin, or tetracycline combinations to wipe up the present microbiota from the intestine of the patient and to put the new microbiota, so that there will be better engraftment of the microbiota. Side effects of FMT. The common side effects are very rare. Common ones which can be easily manageable: mild fever, diarrhea, vomiting, like that, which are transient and remains for 24 to 48 hours. Serious side effects can be the IBD flare, enteric pathogen transmissions, and other transmissions, and perforation and aspiration in case of capsule FMT. The rare side effects, there can be a transmission of traits like obesity. One patient who has received the FMT from obese person later develop obesity, and there can be emergence of the new diseases like the allergic bronchitis, arthritis, depression, and urticaria. So, what are the factors responsible for the successful engraftment of FMT? Post-immune responses. If the patient, if the host is having the higher immune response, there may be less engraftment. Then the dietary pattern, patient should follow the avoid pro-inflammatory diet like animal proteins, animal fat, dietary fat, and food additives and emulsifiers. And it is again related to the proportion of specific bacteria in the donor feces like Faecalibacterium pyogenesis and Clostridium clusters. The factors influencing the outcome already discussed, like younger age, early in the course, extend up to E2, endoscopic Mayo score up to 2, and on stable doses of concomitant medications, including the age-matched donor. So the last point, what is the status of FMT in COVID era? So we just Sagar sir had told that COVID-19 viral RNA can persist in the stool even in the absence of respiratory symptoms. So the possible transmission of the feces, hence need to test the donor at multiple time points, and we are not out of COVID era still. And FDA has given statement that we should use donated stool, which has been donated before December 2019, to avoid transmission of COVID. So the key learnings are, the IBD is a complex disease which involves dysbiosis. FMT is evolving therapy and not curative one. Firm indications for FMT are not established as in IBD as those established in RCDA. FMT can be advocated as first line, cannot be advocated as first line therapy. It is generally found to be more efficacious in CD. It is more effective in early disease and on stable doses of immunosuppressants. More effective when given in multiple sessions. More effective when used multiple donors. More efficacious as by upper GI, lower GI route in UC, and upper GI and lower GI both can be routes can be used in CD. Post FMT diet of recipient plays an important role in engraftment of microbiome, and side effects are generally minimal and acceptable and easily manageable. Still, the use of FMT remains an experimental therapy unless issues with FMT are not solved fully. Thank you. These are the areas of future research in FMT.
Thank you, Prakash. It's a very interesting topic actually, and you have very nicely covered all the aspects of it.